Assalamu alaikum and welcome to the recorded lecture on CTG interpretation 2. This time we're going to look at the abnormal CTG and look at features on the CTG that can tell us or give hints about actually features that is compromised. We want to, and our objectives in this lecture are to understand what an abnormal CTG can tell us, practice our systematic approach to CTG interpretation that we have already learned in our first lecture on CTG, discuss some of the most important features and their abnormalities in the CTG. Finally, we will look at some examples and also will discuss purpose and use of fetal blood sampling. So first of all, the important question, what can an abnormal CTG tell us? And I want you just to think about this for a little a second, because people think if they see an abnormal CTG that correlates with specific causes, but this is not the case. So an abnormal CTG can only tell us that there's the possibility this fetus is compromised, and often we need to investigate further to understand the actual situation this baby is in. Frequently, we have abnormalities on the CTG, but they are abnormalities that happen with absolutely normal babies. Okay, I just want to remind you before we go on, I want you to remind you of Dr. C. Bravado, so that you start with determining the risk, then look at the contractions, look at the baseline rate, assess variability, look if there's any accelerations on the CTG, look for any decelerations that you might see, and then make a plan, an overall assessment and plan for further kind of management of this patient. Please have a pen and paper with you for this lecture, so you can kind of make notes as we look at CTGs. You can look at them yourself and see what you find as when you look at it, and then compare it to my interpretation. So first of all, to remind you how we take the CTG, I have already said that in the first CTG lecture. The external monitor, which is usually used and much more commonly used, has two probes. One that is put on the fundus for the tachography, so the monitoring of the contractions, and the second one, the Doppler sound effect probe, is put on the lower down the mother's abdomen. If the baby is cephalic, it has to be usually put below the umbilicus, and to monitor the fetal heartbeat. As an alternative, there's this fetal scalp electrode that can be used only during labor when the membranes are broken and the cervix already open, and it helps if there's a lot of loss of contact. Then this probe for fetal monitoring keeps the contact available. Okay, so let us start with some baseline abnormalities. A tachycardia is defined when the heartbeat of the baby is continuously above 160, and a bradycardia if it's persistently below 110. So this is a picture of a CTG, and I know you want to now look at, there's a tachycardia and it's labeled, and that's true. But I want to ask you to take a few seconds to look at all of the features that you can see. So here you start with at the contractions. You see there are contractions there, 2 in 10 minutes. Then you see the baseline rate is 180. variability appears normal to possibly slightly reduced. There's no acceleration and also no deceleration seen on the CTG. So, what can be the causes of a fetal tachycardia? Write them down with your pen and paper and see if you have the right. So, first of all, fetal tachycardia can be an expression of fetal activity, which is of course a good sign. But fetal activity is never continuous. So, if you have a fetal tachycardia, you will see that it at some point terminates. So at some point the fetus is tired and will have a rest, same as you when you do exercise or walk or run. Then after a while you get tired and you want to have a rest, and this is the same with the fetus. Fetal activity is also associated with usually good variability, normal variability. Other causes of fetal tachycardia can be maternal pyrexia or chorioamnionitis. A fetal bradycardia, we have already talked about this in our first lecture, is defined as a heart rate of below 110 for over 4 minutes. Everything between with a bradycardia or baseline rate of below 110 between 2 and 4 minutes is termed a prolonged deceleration. And here you can see some prolonged decelerations. So again, you see contractions, 1 in 10 minutes, 1 contraction every 10 minutes, or 1 to 2, let's say, contractions every 10 minutes. And with these contractions, you can see that they have also got long decelerations as long as they last, and about 3 minutes. You can see three squares for these decelerations. The variability is reduced. The baseline rate is around 150. The variability is reduced. There's no deceleration, but there are these long, prolonged decelerations. This is another example. You see in this very short, only brief, this is not usually long enough to interpret the CTG. It's just used to demonstrate what a prolonged deceleration might look like. But you can see that this deceleration lasts about 4 minutes. So you see 4 squares between it. It lasts about 4 minutes. And in this picture, if we interpret it, we can see that there's that there are contractions, but we cannot say if they are regular or not, because later on this appear to be disrupted by some movement artifacts. If we look at the CTG, we look that the baseline rate was between 140 and 150. That the variability is good. There's no accelerations on this CTG, but deceleration. We see then a sharp decrease in the baseline rate, going down to 60 and staying there for more than 4 minutes. So this means that it is a fetal bradycardia. This is a severe abnormality in the CTG and needs immediate action. So please have a look at this CTG and write down on your notepads what you see. Yeah, so I'll start. If we look for contractions at first, it is maybe there are some tightening, some contractions, but they are not regular contractions visible here. Then you look at the CTG and you see 2 recordings. The first recording, the underneath the line, looks as a recording of the maternal pulse. and the line above is then the highest line is the fetal heart activity. You can see that the normal baseline rate was around 140, and variability good. A few little accelerations even possibly seen, but then you can see a drop in the baseline rate with um, actually probably a prolonged deceleration of 4 minutes. So this is just on the borderline between prolonged deceleration and fetal bradycardia. And then you see a recovery of the baseline rate, and there seems to be a compensation of this baby, and then at at first, so the recovery is to first of all a fetal tachycardia, so it would need to be seen what happens in the CTG later to see how this goes on. So what is the significance of a prolonged deceleration, such as we have seen in the CTG just before? This is the reaction of to an acute event of hypoxemia. So it could be cord compression, it could be a very strong and long contraction, and such a contraction can sometimes be induced by induction of labor, or it could be reduced fetal reserve, fetal compromise that shows itself for the first time as a prolonged deceleration. Then you see that the fetus rallies and kind of recovers from it, but you have to have a very close eye on such fetuses that show prolonged decelerations, because they can also be due to a reduced fetal reserve, which means that if contractions continue, get stronger, and so on, the fetus might not be able to cope with normal labor. So what is the significance of fetal bradycardia? I have also already mentioned it very briefly in a previous CTG. Fetal bradycardia is the expression of severe fetal compromise. So the baby experiences a sharp drop in the baseline rate and cannot rally from this. So the fetus is the fetal reserve is compromised in such a way that they cannot on their own recover from this fetal compromise. So it's an inability of compensation that the fetus can do, and it needs immediate action. Okay, so immediate action means immediate operative vaginal delivery if the patient is fully dilated and the head is low in the pelvis, or alternatively, if the patient is not fully dilated or the head is very high, it needs immediate cesarean section. In this, we employ the rule of 3. Which means if there's no sign of recovery of the baseline rate after 3 minutes, you have to call for help. After 6 minutes, you should move to the theater. After 9 minutes, you should prepare for delivery, and after 12 minutes, start delivery. After 15 minutes, the baby should be delivered. This is the rule of 3 that applies in the presence of fetal bradycardia. So again, you can see a CTG here. Just take a minute to go through and write down the parameters of the CTG in a systematic way. So if I tell you now, and then you can compare your notes to mine, you can see that this patient has contractions, and it seems to have 5 to 6 contractions every 10 minutes. So this is quite frequent contractions. The CTG, the baseline rate, is normal. I cannot see the actual number, but it is a normal baseline rate initially with normal variability. You see occasional slight drop in the heart rate, but quick recoveries. And then at some point down the line, suddenly you have a sharp drop and the baseline rate does not recover. This is 4 minutes, and it goes on down. So we see 4 minutes on this strip, that it remains low, and I guess that it was not continued on this strip because then preparations were made for delivery of this baby. Okay, so if we look at the variability, variability is normal if it's 5 to 25. It is reduced if it's 5 or less, and it's called increase or saltatory if it's more than 25. To just remind you how we assess variability, I show you this picture. You can see the little red marks that go to kind of measure the variability on the CTG. Often we just eyeball variability, and this is fine, especially with kind of more experience. On this CTG, it's easy to see that the variability is normal. If we look systematically at this CTG, we can see that there are 2 contractions or tightenings in 10 minutes, that we have a normal baseline rate, normal variability with acceleration and no deceleration. So this is a normal CTG of a patient who's probably not yet in labor. As a comparison, I want to show you this picture that illustrates reduced variability. Again, you see a patient who has about this patient has about 3 contractions in 10 minutes or tightenings. We are unable to say. Sometimes you see such little changes on the CTG, and they represent tightenings. But they might also represent contractions, and that is if they are painful and if they also kind of put the patient into labor, so cause dilatation of the cervix. If we then look at the baseline rate, we can see that it's 150. The variability in this patient is reduced, and you see no acceleration and no deceleration on the CTG. Reduced variability is worrying. So variability is the let's look at just write down what you think the significance of variability is. So variability is reduced variability indicates fetal compromise, or might indicate fetal compromise. The variability is an expression of the sympathetic and parasympathetic nervous system of the baby, and if you kind of have hypoxia, you find that there's kind of an accumulation of lactic acid, and this leads to the appearance of this reduced variability. We find reduced variability sometimes could be normal, and this is in one case when the baby is asleep. So as adults, babies go through phases of sleep when they do not move much, and when their kind of metabolism, energy expenditure, everything is kind of cut down to a minimum, and they just rest. During these phases, which last typically about 20 minutes, the CTG looks much calmer than otherwise, so you don't see accelerations, and the variability might also be reduced in such traces. Okay, we call this a sleep trace. However, it is typical when we see such a sleep trace that it should recover after 20 minutes, and if it does not recover after 20 minutes, typically you wait until 40 minutes and see if it recovers. You can give some stimulation to the mother, such as a cold drink, to kind of make it recover and stimulate the parasympathetic nervous system. But if there's no sign of recovery after 40 minutes, this is a serious finding, and some action has to be taken. Sometimes it can also be drug-induced. If patients are in labor and they receive opioid drugs, this can also lead to kind of a dampening of the variability. Increased variability, on the other hand, is if the variability is above 25. This is a very rare finding. Sometimes you find this increased variability for a brief period of time, but only if it's kind of lasting longer than 30 minutes is the trace called a saltatory CTG. However, a saltatory CTG is extremely rare. Some publications say it probably does not exist. However, you do find shorter periods of increased variability. They are also rare, but you do find them again as a response of the autonomic nervous system to a sudden severe hypoxia. When they do not have enough time for the release of catecholamines so that the sympathetic nervous system reacts to obtain more catecholamines. And the parasympathetic nervous system reduces the cardiac workload. So saltatory or increased variability expresses an exaggerated autonomic response and can be seen as an abrupt up and down in the CTG, such as here. But you can see here after 6 minutes, the CTG, the variability comes back to normal. You can see this in this trace as well. So there's a period of 6 minutes of increased variability, but then it comes back to normal. Okay, so let us now look at decelerations on the CTG. We have, as we said last time, 3 forms of decelerations. These are early decelerations, late decelerations, and variable decelerations. We start with early decelerations, and this is a typical picture for early decelerations. You see contractions in the CTG, only 1 every 10 minutes. But corresponding to this, the baseline rate is normal at about 150 or 140. The variability appears a little bit reduced, and you see, but you see one acceleration between the first and second deceleration, and then you see the early decelerations, which are a mirror image of the contraction. So what is the significance of the early deceleration? Yes, they are again very rare. They are an expression of head compression, of the compression of the fetal head in the pelvis, and they are usually benign. So they are usually not to be worrying about too much. Also, you find that they are rare because the fetal head gets compressed once it's very engaged and deep down in the pelvis, and this usually happens only in the second stage. So late decelerations. So what another thing I want to just put your attention to: early decelerations. You can only call decelerations early decelerations if they all look the same. Okay, they have to be all kind of have this similar or the same shape, so that you can call them early decelerations, such as illustrated in this CTG. Late decelerations again appear, all of them similar. They are kind of typically the deceleration start to descend when the contraction is at its peak, and this is demonstrated in this CTG. You can see there are regular contractions visible in this CTG, maybe 2 to 3 in 10 minutes. And if we look at the fetal heart rate trace, it has a normal baseline rate. It appears to have a reduced variability, and it has late decelerations. And these start with the peak of the contraction, and then after the contraction has gone, they take a while to recover and go back to the baseline. So what is the significance of late decelerations? So the significance of late decelerations have to be understood within the clinical context. Okay, it can be that they are due to excessive uterine contractions, to maternal hypotension, maternal hypoxemia, or they can be an indicator of fetal compromise, such as a reduced placental exchange, so insufficiency of the uteroplacental unit. This can happen typically in hypertension, in preeclampsia, or diabetes. They can be occur in babies with IUGR who are already antenatally compromised, and where the the uteroplacental unit had been not functioning effectively and efficiently before the labor. And they can also occur in abruption, when the abruption maybe is only partial. Some transfer of blood remains to the baby, but this is severely compromised. So it is very important to assess the whole of the CTG as well as the clinical situation when looking at the significance of late decelerations, but they do need action. Okay, when you see late deceleration, you cannot say, we'll wait another 30 minutes. You have to make a detailed plan on how to manage this patient. Finally, we come to the last form of decelerations, the variable decelerations. Variable decelerations are the most common type of decelerations on a CTG, and I will excuse you if you're not sure what type of deceleration you see on a CTG. Then you should always say variable deceleration, because it's most likely to be variable deceleration in that case. Variable decelerations, what's the significance of variable decelerations? They are usually often seen in the second stage of labor. They often are caused by cord compression. But evaluation of the whole trace and the clinical situation are also essential when you see variable decelerations. So basically, variable decelerations are not normal, but they are often seen with babies that are normal. However, if they continue for a long period of time, then with time, this baby will be compromised, and with time, this will become abnormal, this baby, and need serious or urgent intervention and urgent help. So variable decelerations, just to finish, to kind of come to that, we'll see some pictures later on in my CTG examples, but I just want to say that variable decelerations are decelerations that are not connected to the contractions. They appear anytime, and they come and go and appear anytime with the throughout the trace and in correlation to the anytime in correlation to the contractions. So they have no relationship to the contractions. So now we are coming to the part where we are going to look at some CTGs, and you will get the opportunity to take a few seconds and look at CTG yourself at first, and then we'll discuss it together. So we'll start with this CTG. Some of these CTGs are difficult actually and not that clear, but I want you to just try yourself. So take your pen and paper, write down the features of the CTG. Be systematic with it, and follow the Dr. C. Bravado abbreviation. Okay, so first of all, you look at the contractions, and you can see that this patient has contractions. It looks that they are 2 to 3 in 10 minutes. Then you look at the fetal heart rate trace, and you see a baseline which is normal. Now here I want you not to be fooled. The baseline is around 120. If you look at the start of the CTG, you see a baseline, and then you see the drop in the baseline, and followed by a brief stint of actually bradycardia. This is more than just a prolonged deceleration, it's a bradycardia. And then the baseline recovers to about 120 in the middle, and it remains at 120 about 5 minutes, and then it goes down again, and another deceleration for about 4 minutes when it recovers again. So this is not an acceleration. The last little mountain you see in this CTG is not an acceleration. It's actually the recovery of a deceleration, but it goes down quickly again. So this baby is severely compromised. It cannot properly recover from a high kind of phasic deceleration or bradycardia, a period of bradycardia, and it really needs urgent help here to kind of come to be delivered and not become more unwell. So again, take a few seconds to look at the CTG and write down the parameters in a systematic way. Yes, let's start together. This patient again has got contractions, and you can see again they are about 3 in 10 minutes. You can see the two lines of going through the CTG. They are 10 minutes they say 10 minutes, so 3 contractions in 10 minutes. If we look at the fetal parameters, again we cannot read the baseline rate, but it is on the right line, so the baseline rate is normal. Acceleration again is normal. You can see no proper deceleration, and there's no proper acceleration either. Maybe a small acceleration towards in the 1, 2, 3, 4, 5, 6 square that you see at the beginning of the 6th square that you see. There's a small acceleration there, but the little peak to the down is not a deceleration, as it's not long enough to be a proper deceleration. Okay, please take again a few seconds to look at this CTG. So here we start again systematically with the contractions. You see 3, 4, 5, 6, almost 6 contractions. So 5 to 6 contractions in 10 minutes. So what is the normal number of contractions in 10 minutes? Yes, 4 to 5 contractions in 10 minutes is normal. So 6 contractions in 10 minutes seems a lot. Maybe this is induced, but maybe this patient undergoes induction of labor, and this is kind of a hyperstimulation of the uterus. If we now look at the CTG, we can look at the baseline rate, and the baseline rate is around 160. At the beginning of the CTG, you can see that. And then you see some deep decelerations. They are not prolonged because they are less than 1 minute or around 1 minute, and then they recover, and then they go down, and then they recover. So, but they are deep decelerations, and after the third deceleration, you can see that the baby compromises this state with a heart rate of around 180 or even 200. Okay, so in this baby, you have to have a look what happens down the line. So we should have a look at the longer CTG, but the second half of the CTG represents a fetal tachycardia. The variability appears slightly reduced in this stint of the CTG, and it would depend on how quick this CTG recovers, if this kind of can be tolerated and observed, or if it should be requiring immediate action. Okay, so I want you to have another look at the CTG again. Okay, so we can see again, this patient has got contractions. I can see 2 to 3 in 10 minutes. If we look at the parameters, we see that the baseline rate is normal, around 140. Initially the variability is reduced, but then in the later half of the CTG, you see actually a normal variability. So it recovers to normal. We see there's no accelerations visible on this CTG, but one deceleration, which is a prolonged deceleration. It lasts about 3 minutes. And if you see, I want to kind of just make you aware of this, it appears to correspond to a prolonged contraction. So if you look down at the CTG, you see one prolonged contraction, and the deceleration appears to kind of be corresponding to that contraction. When you have contractions in labor, it reduces the blood flow to the uteroplacental unit, or to the baby, from the uteroplacental unit to the baby. Contractions reduce that blood flow. Usual healthy babies can, with a normal labor, they will be able to compensate for this reduced blood flow in between contractions, and you will not see this reduction on the CTG. However, if the baby has got a compromise, or if you have very frequent or very strong and long contractions, then the baby might not have enough time to compromise in such an efficient way that it's not visible on the CTG. So in those cases, either the baby has got some fetal compromise that does not allow it to kind of recover itself and compensate well enough, or it has got the contractions are too frequent or too long, so that the recovery time is too short for the baby to really compensate for this kind of reduced flow during the contraction. In this case, it might well be that this one long contraction might have caused this long deceleration. But only a longer kind of observation of this CTG will actually tell you this, will give you the full story to this problem. So, another CTG. Okay, let's start again. 2 to 3 contractions every 10 minutes. You can see between the rows of the numbers down, you can see 2 to 3 contractions in 10 minutes. If you look at the fetal heart rate trace, it is around 120. The variability is good. You see several accelerations on the trace, and there's no decelerations. So this is a normal CTG. Again, have a look at the CTG. Okay, let's start with looking at for contractions, and there's no regular contractions on this CTG. There are a few contractions. I can see 3 contractions altogether. That might be contractions. They might also be tightenings. This is unclear. In fact, you can see this little up and down in the row. It's not kind of one line, but it's kind of a wavy line. If you see such a wavy line, it can often represent, not always, but often it can represent what we call uterine irritability. And this is something that is found especially when you have infections, and it might kind of cause this sort of appearance on the CTG. When we look at the fetal heart rate trace, we see that the baseline is increased. It looks as sitting about 180 beats per minute. The variability is good, and you see one deceleration and no accelerations. So what is the overall impression that you get from this CTG? That's right, this is a fetal tachycardia. Now you have to think about what causes this fetal tachycardia. And together with the little wavy line that you see at the bottom, which is often seen in the face of chorioamnionitis, this might well be one appearance of so it might well be an appearance of or an expression of a chorioamnionitis. This CTG might well be an expression of a chorioamnionitis. However, there can be other causes. It can be that the patient has got an infection like influenza or something like that, which causes her to have a temperature. This is something that needs to be assessed in the clinical context. That goes beyond our lecture here because we only want to kind of get kind of practice to look at CTGs at the moment. Okay, let's have another CTG then. And here you see a patient who has around 2 to 3 contractions per minute. You can see that this CTG has, you can see the smaller, the larger squares are a bit smaller and more together. And set 10 minutes are between the two number lines always. Okay, so they appear a bit closer together on this CTG. Contractions are regular, so this patient appears to be in labor. But only we could see that from the clinical situation, but this patient appears to be in labor. If we look at the baseline rate now, we can see that it was 120 at the beginning of the CTG, and then you see a drop, and this drop lasts for a while. Okay, so it lasts for maybe 10 minutes, then it recovers a little bit and it drops again. It recovers and it drops again, recovers and drops again. At the end of the CTG trace, that part, it appears to normalize again to the original baseline rate. But this is a picture of a fetal bradycardia. So I think we had a trace like that before. Let us look at this trace. So again, we start with the contractions and we see 4 to 5 contractions in 10 minutes. Then we look at the fetal heart rate trace. This appears to be about 130. Variability is normal. We see on this trace only 1, 2, 3, 4 accelerations and no decelerations. So this is a normal CTG, a reactive CTG. Okay, so this is a CTG trace as it comes out of the machine. And you can start with looking at the contractions. You see 2 contractions on this CTG. So in the first 10 minutes, there's none. Then there's 1 and 1, or maybe these are tightening. So only 1 in 10 minutes. This patient is not yet in labor. There's no regular contractions yet. Then you see a small recording, and this is one of the CTGs that also records the maternal pulse. So you see the recording of the maternal pulse, and then the up line, the kind of the highest line is the fetal heart rate, and we can see that the baseline is normal. I cannot read the number, but it is a normal baseline. The variability is normal, and you see several accelerations on this trace. So this is also a reactive CTG. Now, have a look at this trace and take a short while to just interpret it for yourself. So starting with the contractions, this patient has 2 to 3, or let's say 2 contractions per 10 minutes. But then these contractions do not appear to be regular, because then she has a longer period without contractions. So this would need to be assessed on a longer trace and in the clinical context. But then you see a baseline rate of 120, a normal variability. You maybe see 1 acceleration down at the last kind of little hump is possibly an acceleration. But then you see late decelerations. So these are late decelerations that occur and start off actually, with the heart with the fetal, the contraction, and then go on. Actually, they do not look quite the same. So it is actually more likely to be variable decelerations than late decelerations. Also, the first deceleration, you see a little hump on a little shouldering at the beginning of the first deceleration. So this is a picture of variable decelerations. All of them look different, and they are slightly different in the timing with the contractions. So this is something that would have to be observed and looked at, what's going on with this baby. Now have a look at the CTG. The CTG also has 1 to 2 contractions per 10 minutes. The baseline rate is normal of the CTG. Initially, the variability seems reduced and there's 2 small decelerations visible. But then at the second line after the second contraction, if you can see, the variability becomes normal, and also there's several there's one acceleration to be seen on this trace, and this is followed again by several more decelerations. These decelerations look different everywhere in all sense. So no deceleration is the mirror image of the next deceleration. They all look slightly different, and these are typical variable decelerations. So if we look at, just want to finish, sorry, I moved on a little bit quickly here. Just want to finish the overall assessment of this CTG. The overall assessment, of course, has to be within the clinical context, but this CTG is not normal, but it also does not require immediate urgent action, but it needs close observation and a good plan. So this patient, this baby, if the CTG recovers after that and continues normal, might kind of continue with the labor normally. But if this continues with the decelerations, then it is worrying, and it might represent some fetal compromise that needs some more urgent action. So this CTG, again, you see 3 to 4 contractions per minute, and these are regular contractions. This patient seems to be in labor. If we look at the fetal heartbeat trace, there's a baseline of around 130. The variability is good. And you see, again, decelerations, which are typical variable decelerations because they appear at different stages. And with the contraction, they all look different, and they have some variability at the bottom of the deceleration. These are typical variable decelerations, and there's no accelerations seen on this trace, on this part of the trace. The variability in this trace, and also the one we looked at previously, was normal, and this is a very reassuring sign. So if you have variable decelerations ongoing, but your variability remains good, and you also have some variability at the bottom of the contractions, this is a kind of reassuring sign, but still they need close observation and might need some intervention. So just coming back and reminding you of this abbreviation, Dr. C. Bravado, so that you can always look at CTGs systematically and do not miss any of the parameters. Interpretation of CTGs can be tricky, especially in the kind of routine of a labor ward where it's very busy and you might kind of feel pressurized to do things. Therefore, it is a good idea to categorize CTGs so you know what you're dealing with. Category 1 is the normal CTG, the one which is absolutely normal. We looked at it before. So it does not require accelerations, but if there are accelerations, this is very reassuring. Okay, so early decelerations, accelerations may or may not be present. Then you have the category 3, the absolutely abnormal CTG that needs immediate action and an immediate action plan to kind of and prompt delivery. These are changes that are such as absence of baseline variability, so no variability, recurrent late or variable decelerations. So if late or variable decelerations continue over a long time, or kind of episodic decelerations that continue over a longer time, a bradycardia is also something that needs immediate action. And then we have those CTGs that are in between the category 1, the normal CTG, and the category 3, the absolutely abnormal CTG. And these are the difficult CTGs that you need some that you need to see in the clinical context, and that can kind of give rise to different actions and different interpretations. Okay, it is important to take care with interpreting such CTGs, because you do not want to end up to kind of with any CTG abnormality immediately do a cesarean section, because then your cesarean section rates will rise inappropriately high. But you also, of course, you do not want to miss serious abnormalities that result in fetal compromise and may result in some neurodevelopmental delay after delivery of the baby. So in this category 2 intermediate kind of category belong bradycardias that remain to have a normal baseline variability, and that are kind of only once, and that happen, that are not ongoing. A tachycardia does remain, kind of belong into this minimal and marked baseline variability. Accelerations, so absence of induced acceleration after fetal stimulation. Periodic and episodic deceleration, so longer than 2 minutes but shorter than 10 minutes. Okay, so recurrent late decelerations with moderate baseline variability, and also variable decelerations belong into this, with other characteristics such as a slow return to the baseline, overshoots or shoulders seen, also belong in this category. So we want to look at actions that can be taken as a response to abnormal CTGs. Okay, so you know, and we have already talked about this, if a patient is fully dilated, the head is low, or she's pushing, and you can see the head, you might be able to do just an episiotomy to kind of help delivering the head. You might just kind of tell her push very hard and she might be delivering it, or you might do a ventouse operative vaginal delivery to help this baby deliver quickly. However, if you have those patients that are still far away, maybe still in the first stage, you might need to do some other actions. Okay, and other actions can of course be cesarean section, but we know that the cesarean section rate will rise if we only have the CTG, and make our decisions, especially in category 2 CTGs, make our decisions singly and solely on the CTG appearances with regards to cesarean section. There are some other methods we can take, some other interventions we can do, and the main one is fetal blood sampling. This is an illustration of a fetal blood sampling. It's basically to take a little drop of fetal blood from the fetal scalp, and this we take to the arterial blood gas machine, and in the arterial blood gas machine it will give us a pH. So we do not look at the oxygen or the carbon dioxide measurements too much, but we do look at the pH of the baby and make the decision based on the pH we get. Okay, so fetal blood sampling is done like this. You have an amnioscope, so here the plastic you see as plastic instrument is an amnioscope that you can insert into the vagina and through the open cervix. So fetal blood sampling can only be done if the cervix is already open and if the membranes are ruptured, so that you can see the fetal head. Okay, when you insert the amnioscope, the fetal head looks like this. You can see the fetal head like this. On this fetal head, you will then kind of clean the area. You will clean the area. You will put a little bit of Vaseline cream, and then you will take a little pricker that is like a finger pricker but on a long stick, and you will make a small kind of prick into the fetal scalp, and from that prick that will then form a droplet, because you've put on the Vaseline cream, it will form a droplet, and from that droplet you can collect blood enough to do to measure the pH in a capillary tube. So these are single-use sets for doing FBSs. They include the amnioscope, which is the white kind of tube-like instrument. They include swabs, and they include capillary tubes, as well as a little device where you can put a little pricker on to make the prick into the fetal scalp. And this is how it would look when you do it. The patient is in lithotomy position. You insert the speculum, the amnioscope, and this is how you do this procedure. The FBS interpretation is easy. You will get an immediate result, and every pH above 7.25 is normal. So you can continue with the labor, observe the CTG abnormalities, and only repeat the FBS if abnormalities persist or get worse. Then you have borderline pH, which is 7.20 to 7.25. These are not absolutely normal. They need observation and possibly repeat FBS after 30 minutes. And then you have pH below 7.20, and these are pathological. They need immediate delivery. So here you have just a little bit of a picture showing you category 1, category 2, and category 3 CTGs. The first CTG is category 1 CTG, the second CTG is supposed to be a category 2 CTG, and the last one a category 3 CTG with fetal bradycardia illustrated. So in summary, interpretation of CTGs has to be done within the clinical context. It has to be systematic, so you have to use Dr. C bravado. Abnormalities in the CTGs are found in many normal babies. The CTG is not diagnostic of the cause of the abnormality. And always make a plan. So if you have an observation, an investigation, such as an SBS or immediate delivery, or you say, I will come back and have another look at this patient and at her CTG after 15 minutes, or to kind of see how it goes on. So always make a plan when you kind of review a patient on the labor ward. Thank you very much for kind of joining this lecture, and I will see you again in our next lecture.